Okay, so good morning, everybody. And welcome to this Black History Month webinar. For those who don't know me, my name is Luke Heslop. I'm the service lead for the Public Health Evidence team. And I'm joined by three members of my team today. Tarira and Jen shall be presenting the findings from our deep dive programme in relation to Black and ethnic minority citizens. And Amy shall be monitoring the chat throughout. We are recording this session, and it will be made available to view alongside the array of other webinars that the Public Health team are producing for Black History Month. Throughout this session, please turn your cameras and particularly your microphones off, but feel free to use the chat throughout, which Amy should be monitoring, and there'll be an opportunity to discuss the chat and any other questions at the end. Before I pass over to Tarira, I think a brief background of the deep dive programme would be helpful. So the deep dive programme was established by the City Council's Health and Wellbeing Board as a rolling programme of deep dive reports or in-depth needs assessments to research health and wellbeing inequalities and establish policy recommendations for action. We currently have 4 deep dives which are either published or close to publication, which Tarira and Jen shall be talking about this morning. The 2 published deep dives focus on the health and wellbeing of veterans and end of life in Birmingham, and both are available on the council's website. Amy will put a link in the chat later on. And the learning disabilities and dual diagnosis deep dives are in the closing stages of production, and draft versions are currently available for consultation. Each of our deep dive topics have been chosen carefully due to the inequalities endured by people within that demographic, and the need to shine a light in those areas and create actions for change. Therefore, each deep dive is a thorough, in-depth investigation into the available evidence in relation to strategies, data, epidemiology, services, and lived experience. And we work with stakeholders from across the city to develop recommendations for action and ownership of these. The lived experience element of our research allows us to capture the seldom heard voices of citizens who endure inequalities. And it's an important element of this process. It allows us to engage with citizens from ethnic minority communities to make the research more representative. This focus also applies to other minority demographics, such as migrants, citizens who have endured homelessness, and LGBTQ communities. Lived experience research also allows us to engage with carers and parents, as well as service and healthcare professionals for their valuable insights. Okay, so that's a brief background to our deep dive programme. Now, Tarira and Jen will present the findings from our 4 deep dives. So over to you, Tarira.
Okay, hello everyone. So we'll start off, as Lucas said, with the health and well-being of veterans. So for the purpose of the deep dive, a veteran was defined as someone who has served in the armed forces for at least 1 day, and that also includes those who are reserves. And as we can imagine, being in the armed forces is different from all other occupations because the personnel in the armed forces experience a unique set of factors because of their time in service. And these factors tend to not only affect them, but their families as well. So this does not only include the risk of injury or death, but there's also lifestyle factors such as frequent moves and the disruption that this may bring. And this was an important area to explore for the council, as one of the council's equity objectives is to understand Birmingham's diverse communities and embed that understanding into how we shape policy and practice across the council. And this can be done by improving the collection of qualitative and quantitative data, which is what we do as a team on the daily, and working with citizens and partner organizations. So Jen's going to go through some prevalence data with you all.
Thank you, Tarira. Yeah, when we did the deep dive, we did it pre-COVID, and as such, we'd only really got the 2011 census to look at. So we had a look at what the percentages were of each of the ethnic groups, and we identified that within the white ethnicity group, there was 57.9% at that time. And within the ethnic minority group, there was 42.1. Now, obviously, the census breaks those ethnic minority groups down even further. Unfortunately, the only survey that we could find that would give us an estimate of the amount of veterans across Birmingham was one that was done in 2011, and the only way they did it was by the white ethnicity group and the ethnic minority groups. They didn't go any further than that. So we took the numbers that they came up with, which was England and regional based, worked out the percentage of the West Midlands that would be Birmingham, and then identified within our population the percentages that they had come up with. Now, this gave us 99% of our veterans came from a white ethnicity and 1% came from an ethnic minority group. Obviously, bearing in mind the diversity of Birmingham, the 1% is definitely too low. And hopefully with the new census, we'll be able to actually get a better breakdown. But at the time that we did the report, unfortunately, that wasn't available. Tariro, back to you.
Thank you. So as Luke mentioned, lived experience is an important part of the deep dive program. And during the Veterans Health and Wellbeing of Veterans deep dive, the Council commissioned 2 organizations to run some targeted focus groups for this deep dive. And some of the themes that we covered included what being a veteran means to those who are veterans, their community and relationships, employment, education and skills, finance and debt, as well as their health and well-being and housing. And during this time, it was very important to make sure that we had a representative group so that we could get the views of everyone within this population. And from the coast that we can see, something that came up was again, how diverse the veteran population is, because we might all have a certain picture of what a veteran looks like, but from one of the veterans could see that they mentioned that veterans come in all shapes and sizes. And also the issue of, as you can see in the quote at the top there, the issue of adjusting to civilian society after having lived a different lifestyle within the armed forces. So we'll look at some of the inequalities that are faced by the veteran population. So they experience certain cultural and structural differences that come from adjusting from being in the armed forces to living in civilian society. And this in turn creates an unmet need, as the experiences are often misunderstood by the civilian population, which can lead to difficulties. And this can even become a greater challenge for those who find themselves within the intersection of being a veteran and an ethnic minority individual, because as a veteran, you face certain inequalities, and then this is compounded by the inequalities that you also face as an ethnic minority individual. So some of the recommendations that came about because of the work that had been done in the deep dive was the need for data that will allow us to understand the veteran population fully, as there is not sufficient data at the moment. And the report also showed that GPs were often unsure of how many veterans were registered within their practices. So those local GPs were encouraged to achieve accreditation as veteran-friendly practices through the Royal College of General Practitioners. And there was also a need for greater research that was found by this deep dive, particularly to support early service leavers, young recruits, and female veterans, as well as just general research around veterans, which again will also help give us more information about the ethnic minority population. In turn, the more information we get about veterans in general will affect all the populations within the group of veterans. So the next deep dive that we'll look at today is the end of life deep dive. So death is something that affects us all, and this report was exploring the data and evidence around what causes death at different stages of life and within different communities. And it was an important topic to explore, as the council's long-term ambition is to have a city where all citizens can die with dignity whilst receiving compassionate and high-quality care, and also to be able for people to be able to speak openly about death, as in certain cultures and certain groups, it's not something that we're able to talk about openly. Jen's just going to go through some prevalence data now.
Right, so from an end of care life perspective, we are looking at generally that previous 12 months to when you die, So the way we got our prevalence for this particular one was from the QOF Palliative Care Register. Now, unfortunately, because it's QOF, we within public health do not actually see ethnicity, gender, or anything like that. And on the register at the time when we actually did the report, there was 4,547 people currently undergoing palliative care, so identified by GPs as being, unfortunately, people with a terminal disease. So what we also looked at was we tried to identify, so we could get an ethnic split of the city because of how diverse we are, how many deaths there were, and then we looked at the only source that we had where we could see identification of ethnicity, and this was basically for deaths in hospital. And during 2018-19, there were a total of 3,991 deaths. That doesn't mean that there was only 3,991 people that went into hospital by any stretch of the imagination. It was more like 300,000 people. But of those, 2,800, which was 71% of the deaths in hospital, were from a white background, and 230, which was 5.8%, were actually from a Black ethnicity. However, as you can see quite clearly, there's another 4,500 people who died during 2018. And obviously that hopefully would give us a far more better split of the Black ethnicity. At the moment, ethnicity is not recorded on death certificates, so it doesn't really help us when we're trying to really explore what the population of people is in that last year of life.
So for the end of life deep dive, several organizations are commissioned to run some targeted focus groups. And out of these groups, 6 groups were chosen to particularly focus on to make sure that it was representative of the actual individuals who are affected mostly by end of life. So this included working age adults with physical disabilities, residents of Heartlands Ward due to the ward having the lowest life expectancy in Birmingham, people with long-term conditions, the LGBTQ plus community, as well as young people and the homeless population. And as you can see from the quotes that we chose to share here, one of the main themes that came about is the opportunity to make a choice and to have your choices honored as an individual as you get towards the end of your life. So this again shows the importance of having that lived experience aspect, because we really get to hone into the insights and to the actual experiences that are on the ground, to the people, the population, and how they actually, what's important to them and what they want you to know, which again will help us with service provision. So in terms of end of life care of ethnic minority groups, as we know, Birmingham is one of the largest has one of the largest population of ethnic minorities in the UK. And despite that, there is an unmet need particularly to do with end of life, due to the disparities in access to palliative care as well as end of life care. And this is a well-recognized issue. So when compared to the white British group, ethnic minority groups are recognized as having a lower access to palliative and end-of-life care services. And this is associated with a lack of referrals, lack of awareness of relevant services within these communities, as well as previous bad experiences that they might have had, which hindered them from accessing any further services that they need. And there's also a lack of information in any relevant languages or formats. And within certain communities, there's also an issue of religious values and families conflicting with the idea of hospice care. And one thing that drives all of this is, research has found, is the poor communication between healthcare professionals and patients. And this, again, was associated with the lack of sensitivity to religious and cultural differences and a lack of availability of translators, as well as lack of training amongst healthcare professionals. And then we also found that in relation to the actual population in Birmingham of ethnic minority groups, there's limited information available regarding their experiences of end-of-life care. So some of the recommendations that came about at the end of the deep dive was the need for all services to be culturally competent and accessible to all service users, as well as the importance of raising awareness of the services that are actually available to individuals, and also putting extra community support that will help communities where they are, especially where there's more complex, like traditional family values or cultural values. And the next deep dive that we're going to look at today is the learning disabilities deep dive. So this deep dive report focused on learning disabilities in Birmingham, but it's important to note that it was not a learning difficulties, as this is something that can often be confused by the general public. However, these definitions are not interchangeable, because the difference is learning disability affects general intellect, whereas learning difficulty doesn't. And the evidence shows that there's an unmet need for improved services within this population, and this has resulted in poorer health and a lower life expectancy. And it was important as a team, for the council and as a team, to explore this topic, as the Health and Wellbeing Board strategy recognized that there's significant health inequalities that affect citizens living with learning disabilities. And one of its commitments is to close the gap. So this means that citizens living with learning disability should not face any disadvantage compared to any other citizens within the city. Now, Jen's going to go through some prevalence data with you.
Yeah, we were fortunate in the sense that we were able to get a lot more learning disability data across the whole life course than we have in the two previous deep dives that we've looked at. And this, I must emphasize, is only some of the data that we found. The QOF data is based on anybody who has got a learning disability that is age 14 and over. And we were rather concerned that that doesn't give a true picture of all the people in Birmingham that have got a learning disability. And we quite sneakily managed to identify somebody who could actually give us genuine numbers of LD patients across Birmingham. And we were very fortunate that the ICB agreed to allow us to have this data. So we compared it against the census, and it showed that from the white ethnicity, approximately 47% of those on the LD register, which is all of them, not the QOF register, are on there. So it's sort of close to the actual census number, but not spot on maybe, but there could be reasons for that. But from a Black ethnicity, it was quite a lot lower, and it was only 8% versus 11. And we believe that some of this is because cultural differences mean that people do not go to their GP practice if they've got a problem like a learning disability. They might be embarrassed. It could be anything really and truly, but they certainly do not engage with GP. And as such, that's not then recorded. Adult social care, which is only 18 plus, however, did kind of match the census really wonderfully. And they actually support 199 individuals at the moment within the Black community that have got a learning disability. And this is, in natural fact, slightly higher than what the census population was at the time. And the data that Adult Social Care gave me was roughly around about the same time as the census. One of the interesting factors that we managed to find nationally, but they did actually do it at a local level, was the amount of carers out there that were from different ethnic backgrounds. And quite clearly, the numbers are very stark when you look at the Black ethnic community, with 19.5% of the people who actually answered the survey, if they were a carer of somebody with a learning disability, actually being from the Black ethnic minority group within the city. What I will emphasise is, though, that the numbers for this survey were exceptionally low. And in truth, that 19.5% may be a lot higher than that. Tariro, back to you.
Thank you. So in terms of some of the lived experience information that we managed to get from this deep dive, we, again, trying to be as representative as we can, we spoke to carers of those with learning disabilities. We also spoke to citizens living with learning disabilities, and we managed to get one of the insights that we really got, which was an interesting one, was to do with older carers of those with learning disabilities, because particularly with the quote at the top left here, what we managed to realize, what we got from it was this individual was being cared for by their mother, but then they got poorly due to age and had to go into care, and they were moved very far from them, so they were across the city. And these are some of the things that are not taken into consideration when moving carers away from the people that they care for. And this was an interesting insight that wouldn't have gotten if we had not spoken to this individual. And also some of the other things that people with learning disabilities experience, like maternity care. We had one individual's experience where they felt like they kept being talked to like a child, like they were being treated like a child because of their learning disability. Again, these are insights that we can only get from lived experience, which also then inform our research, further informing service provision. And some of the inequalities, as you can expect from what we've discussed so far, that we found is, again, that need for improved service provision, which again is resulting in an unmet need within the population. And one particular thing that we found was most citizens living with learning disabilities feel that whenever they're contacting services, they are constantly having to tell their story over and over again. So you might go to your GP today and you have to explain your life story, go to A&E tomorrow, you start again from scratch. So it's that constant having to repeat your story. And as you can imagine, some of them might have communication difficulties, which can become very frustrating. And for any of us, that would be frustrating, having to go to a service and explaining your story over and over again. So some of the recommendations that came about were, again, there's always as we've seen with the theme, there's always a data recommendation. We do not have enough data, and data is what will help us get a full picture of the population and be able to actually give the correct service in regards to the population. And there was also a need that was found for services to be flexible and to tailor their services to meet the need of people with learning disabilities. And this includes reasonable adjustment, communication adaptations, and equipping the staff with the actual knowledge to recognize where these are needed. And specific services need to be developed to support those living with learning disabilities who are from minority ethnic background, with the understanding that some of them have specific needs as well due to their cultural upbringing or religious upbringing. And also the importance of including these experts by experience in the co-production of services at every level, because like we said, they're the ones who are using these services and know what they need and know where it's lacking. The deep dive also identified that there was an absence of an accreditation scheme for primary care providers in Birmingham. So this is how the GP accreditation scheme was brought about as a recommendation, because it would allow a pathway for further training for staff. And another thing that was realized, we don't have a standardized hospital passport, as this is something that would again help with that not having to tell your story over and over again, as it can help with communication, particularly for those who might have communication difficulties, those who might have language barriers. That is something that will give them a bit of autonomy, and having something that will help them get around whenever they're within these services. And now we'll get to the final deep dive that we're going to look at today, which is the dual diagnosis deep dive. So dual diagnosis within this deep dive is talking about the co-occurrence of substance use and mental health disorder. And the aim of this deep dive was to better understand dual diagnosis at a local and national level as well, because it was an important topic to discuss, as research shows that individuals who are living with a substance use disorder are at a greater risk of having mental health problems, and those with mental health problems are also at a greater risk of developing a substance use disorder. And as you can see with the infographic on the right, there are several factors which can lead to both substance use and mental health disorders. And these include genetics, behavior, trauma and stress, as well as environment. And so these are some of the things that we were exploring within the deep dive. So Jen's going to go through some prevalence data and inequalities data.
So from a prevalence point of view, basically we were only able to utilise those that are actually currently in treatment or were in a hospital setting of some description. Most of this is because there is an absolutely huge unmet need across the city of approximately around 93% of anybody who's a substance misuser actually not engaging with services. From the information that we were given from the provider of services across Birmingham, we discovered that for those who identified themselves as having a dual diagnosis, 71% actually came from a white ethnic background and 4.1% from a black ethnicity. Some of this we believe is that they're not necessarily getting referred properly to the treatment services, or maybe don't even feel that they want to actually access the treatment services. Tarira, could I have a look at the inequalities one, please? These are a couple of the points that we've discovered. Again, it is purely people who've got both conditions. So we had a look at what the average length of stay was for anybody in a normal hospital venue. I must emphasise it's not a mental health hospital. This is a normal hospital. And we identified that on average, people with a white ethnicity who've got a dual diagnosis spend 2.7 days in hospital. Whereas, and this is a huge inequality, those from the black ethnicity groups actually spend nearly 3 times more and spend 8.6 days in hospital. This was over, as you can see, the time period from 2014 through to the end of March in 2021. So we had quite a raft of years to look at on that. And to be honest, the average was more or less the same every single year that we looked at it. Additionally to that, we also looked at referrals to the actual mental health trust from different sources, and we discovered that 72% of those that had been referred over a similar time frame were from the white community, but only 6% were actually from the black ethnic minority group. We believe this is actually quite a huge inequality and needs to be looked at in more depth. Tariro, back to you.
Thank you. So some of the data that we managed to get from the lived experience was from staff and from migrant. We got some good data from migrant citizens living within Birmingham. Obviously, this does not necessarily equate to them being an ethnic minority, but there are also chances of the migrant individual being an ethnic minority individual. But as we can see, particularly from the staff, is that reminder that individuals living with dual diagnosis are not necessarily horrible people. They've just had unfortunate life events happen to them, and this has led to them being where they are. And in the quote at the lower bottom from a migrant living with dual diagnosis, we can see again that that relationship that substance use and mental health has, where one feeds into another. I started taking drugs because of my mental health and swapped demon for another. And the quote, the third quote on the bottom right, talking about how most of these individuals actually want to work, but because of their condition, they're not able to, but it is something that they actually desire to do. And looking at the inequalities, the first one is the hospital admissions, which Jen touched on on her inequality slide, how we have individuals from Black communities spending more time in hospital compared to white counterparts. Another thing that we found was Black British clients were more likely to have been detained under the Mental Health Act compared to white clients, with the rate being 309.4 per 100,000 people in England for Black and Black British people, Black African and Black British people, against 76.2 for those from a white background. And then it was also found that Black African clients were most likely to have been in contact with police services within the previous 6 months compared to other ethnic groups. And so it has been suggested in research that, as we all know, people from ethnic minority backgrounds are more likely to encounter structural inequalities, which interact with risk factors for having mental health problems. And these structural inequalities include experiencing poorer housing, socioeconomic deprivation, as well as racism. And there's also evidence of those from ethnic minority backgrounds experiencing inequalities within healthcare systems, which can lead to poorer mental health problems, poorer mental health outcomes. So some of the recommendations that came about with its deep dive was, again, the need for more data. As you can see, this is a very strong theme that comes out, the need for more data that allows us to understand the actual population. And with some of the sources that do have the data, it's that lack of detail. So there's not enough detail on the gender, age, and ethnicity of those with dual diagnosis. And again, this really affects the service provision and actually understanding what the population needs. And there was also inequalities between citizens with different ethnicity backgrounds, which we need to explore. So this is something that for further research or further exploration, we need to understand more citizens from different ethnic minority backgrounds. I'm now going to give over to Luke for the summary.
Thank you to Rira and Jen for a wonderfully concise summary of our deep dives. It's 4 deep dives in a very short period of time. Well done. And I'm sure this morning we've heard about the Birmingham Deep Dive Programme and how we aim to shine a light on the inequalities that citizens from specific demographics that make up our diversity endure. For example, our veterans that we spoke about, we know there's 1.4% at least, but this is probably an underestimate of our population. We know that within our population in Birmingham, 1% have learning disabilities, although this is again probably an underestimate, probably nearer 2 or 3%. Our citizens enduring substance use and mental health problems, there's a 1.8% estimated need there. And you can see these, if you add these together, it's building a picture of these inequalities across Birmingham. And then if we add on those experiencing end of life, we recognise that sadly that's everyone at some point in our lives too. So this research and these recommendations relate across the board, but in Birmingham is very valuable. It's good to be here in Black History Month to underline how important it is to make our research as representative as possible, therefore, by involving those voices of lived experience, particularly from our ethnic minority communities. And we've heard examples of how we've harnessed lived experience evidence and worked with stakeholders to create recommendations for action. Conscious of time, I can see there's some questions in the chat. So Amy, would you like to address these first? And I'll then welcome any further questions too.
Yeah. So we firstly had a question from Jane asking whether the Veterans Deep Dive explored mental health need prevalence. We've had an update saying that she's found what she was looking for. So I don't know if there's anything more on that you wanted to ask about, or whether that's that question answered.
No, that's absolutely fine. I think I'll go into the report with a little bit more detail. Yeah, I mean, both the veterans' work and the work around dual diagnosis, of course, I have a significant interest in that, especially in view of the work that we're trying to do at the moment. So, yeah, thank you for both for both kind of like updates. Thanks.
Fabulous. And if I could add to that, Jane, I don't think it's in the report, but some work we did afterwards was taking the veteran recommendations to the Armed Forces Covenant in Birmingham, with the aim of refreshing their work. It was a bit out of date. So they've used the recommendations from that report to refresh their Armed Forces Covenant. And the 2 of those recommendations are particularly relevant to mental health. One about being more proactive and preventative in their approach to veteran mental health, and navigating veterans towards accessing support much sooner and earlier in the process, and also investigating how safe spaces can be created to help them.
Absolutely. And I guess for me, it's, I'm so glad, we've talked about experts by experience in this particular case. And one area I know we don't always do very well on is how we incorporate that voice within, kind of like how we respond in terms of development of services and how even those services are offered. And especially with veterans, I think it's so crucial. I mean, and I know this probably we need to speak with our colleagues on the NHS side of things around how it's not just a question of how the service is delivered, but actually what type of service and the interface between, the delivery and the content of the service that incorporates that lived experience voice. So thanks for highlighting that.
Thank you, Jane.
Thank you. And then there's another question in the chat from Chris. So the question says, although the Veterans Deep Dive identified a difference in ethnicity group proportions compared to the census data, did you compare with ethnicity data of the armed forces personnel?
This is a data question. I'm going to invite Jen to answer this one.
I knew you'd say that, Luke. Right, Chris, at the time that we actually did the report, we couldn't actually get that information from the MOD. In fact, they quite willingly admitted that they didn't really have very good keeping of that sort of level of data at all. And it was also highlighted in a report by a subcommittee of the government that more data collection within the MOD needed to be done, particularly on veterans. They seem to know about what was out there when somebody was physically serving, but once they actually left the service, they really did not know where that person went. And I even tried SAFA, who pay all the pensions, and even they couldn't tell me. They knew the bank account of the individual, but they did not know where that person lived, which to me at the time when I did the report, I just found absolutely, totally astounding that they couldn't give me that piece of information. Yeah, it was very, very, short on data in any aspect, not just from the ethnic communities, it was across the board. But hopefully now that it's been recognised by ONS that there's a need, we might get some better in the 2021 census.
Great, thanks, Jen.
And that could potentially lead to an update of that report.
And that's everything that was in the chat question-wise.
Thank you, Amy. Before we close up, are there any further questions from anyone here today? Okay. Take that as a no. We'll get about 20 minutes back of your day. Thank you everyone for attending and for the engaging questions as well. I hope you found it interesting. Please get in touch if you'd like to engage with the deep dive programme further in any way. Amy shared an evaluation form in the chat, which I encourage you to complete if you have the time. And finally, thank you for your time this morning, and have a lovely day.